So it's kind of weird. It's just crazy how I went from ICU to ER because I feel like I'm kind of like in the middle, you know, like my personality and everything's like right in the middle, so I can kind of like dabble in both, you know, so I don't know. Hi guys, I'm back for another video. If you guys are new, my name is Yasmin. I am a nurse. I currently work in a pediatric ER trauma room, and I have a 16-month-old baby, so I am a mother, hence all the videos in my past that I've done about my pregnancy. But if you are back for another video, welcome back, and let's get started. So today I'm doing ER versus ICU. I personally have experience in both, which I feel like you're either an ICU nurse or you're an ER nurse. They're completely opposite worlds, and their personalities, I cannot speak, are different. So yeah, I've actually done both, and I've transitioned to both very well. So this is all like my personal experiences on ICU and ER, what the differences are, and yeah, so let's just get into it. Personalities of ICU and ER. So ER is definitely going to be more of like you're able to adapt more, you're able to work in like a chaotic environment. It can be very disorganized looking in to the ER, although everything has kind of like a controlled system behind the chaos, but it can look very disorganized, and you're able to do a million things at once, manage a million things. It's very fast paced, so you have to be someone that can adapt to that and be able to like kind of keep up the speed and do everything and get everything done, because you're basically trying to get patients in and out, in and out, in and out. So that's how it's gonna go. But they're very adaptable. They pretty much look at the big picture. We're not looking at little details. We're not looking at every system. We're not looking at one minor thing that's not critical or not an emergency, because it is an emergency room. We're kind of looking at the big picture, the big major thing that's going on. We're gonna fix it, get you out. Like that's kind of our goal. So that, yeah, that's kind of how we look. Everyone kind of looks at us like we are disorganized. That's the one thing that if you probably ask an ICU nurse what an ER nurse is, they probably would say disorganized. Which honestly, I feel like we keep it together. Like when I was an ICU nurse, I would definitely say like ER nurses are disorganized and they just leave patients a mess and nothing's together and all these things. But like now that I work in the ER, I feel like we keep it together, guys. Like we are it. Like it might look disorganized, but like we have everything in a system. We get things done. Like we are getting things done. That is the goal, and that's who we are. So yeah, that's ER. ICU on the other hand is like, to ER nurses, ICU nurses are like annoying because they want to know everything. Like they're not looking at the big picture. Well, they are looking at the big picture, but they're also looking at all the little things that make up the big picture. They're not looking at just the major problem. They're looking at the major problem plus all the little problems, and they're trying to fix everything. They're trying to manage everything. They're looking at every system. They're doing full assessments and all that stuff. So that's kind of how ICU works. So they're very organized. So if you're an organized person, if you're very meticulous, if you're goal-oriented and just you like planning things out, you like different color pens and pencils and all that kind of stuff, ICU is for you, because that is basically what they're gonna do. They're gonna be organized and meticulous. They're gonna know their day schedule and things like that. They are able to manage a million things. They can manage drips. They can manage 10 drips, 6 lines, an ET tube, a chest tube, 2 chest tubes, let's say. They can order an ostomy bag, all these things, a Foley. They can order all these things and like not be phased. Like when I was an ICU nurse, like my patient, if you came into my room, like it would look like a million things was happening. There was drains and all these things coming out of the patient, and it would look scary, but like we weren't fazed by that. Like I was not fazed by that. Like that was what I loved. Like I knew everything about my patient. ICU nurse, like you ask anything about this patient and they can just like all, my patient weighs 25 kilos, my patient has a central line, they have 2 PIVs, one in the wrist, one in the hand, they have IV fluids running at this rate, they have these strips, this, sedation, all, they can just run it off and like know everything. And ER nurses are like, what's my fluids running at again? 125? Oh no, 100. Let me just look in the chart. You can look in the chart later. Like that's kind of how it is. That's just the difference. So I would say overall, if you are organized and like planning and like everything kind of being constructive and like put together and very detail oriented, ICU's for you. If you are like, I love the fast paced, chaotic craziness that happens. I love being able to just get patients in and out, like all these things. Then that ER is for you. Both of them I feel like are adaptable. You're able to adapt. They're both pretty much fast paced. Because they're just different fast paced. But both, you know, you have to be able to like be quick on your feet and things like that. So yeah, so those are like personalities. We talked a little bit about this, but I'll just run through it. Like fast paced environment, they're both pretty much fast paced. ER is definitely fast paced. There's, you know, you're running a 40 patient waiting room, plus you have like a 45 bed. So all those patients you're trying to get in and out, upstairs, wherever. So it's definitely, you're managing, trying to get all these things done. Everyone has orders, everyone needs a line or needs fluids or needs blood glucose checked or needs an EKG, like everyone needs something. So you're trying to do everything and like get them out. So that's kind of why it's fast paced. Then you're managing ambulances that come in, you're managing traumas that come in, because those you don't know, well, nothing you know is gonna come in or not. So you're kind of just managing all these things at once. So yeah, definitely fast paced. ICU is definitely fast paced as well, but it's different because you have 1 or 2 patients. So your fast pace is like with 1 patient. Like you might have to do like all these meds. They might have deteriorated in some way and you have to emergently intubate them and sedate them and do all these things. Or like you might, or emergently put in a chest tube. Like you might have to do that, but like with 1 patient. So you're working fast and you're doing things very quickly, but it's with 1 patient and not with 4 or 5 patients. So definitely a little bit different, but definitely both fast paced. The intensity levels, you know, the same, but it's just different because you're just more organized in the ICU than you are in the ER. So yeah. What else? It's funny because like you see the memes all the time, like of all the wires, and like that's pretty much how it is. Like in ICU, I used to be like, everything used to be so organized. Like my lines were like pristine. Like my labels, like if I messed up 1 letter on the label, like if I was putting like Versed and like I messed up the S, like I'm redoing that label. Like that's how organized and meticulous I was as an ICU nurse, which is crazy because I transitioned so well to ER and like I love it. But yeah, so everything is like so organized. Everything that you have 10 lines, you have a central line, a 3 lumen that has 3 coming out and then 3 coming out and then 3 coming out, and like everything, you know where everything's at. And an ER nurse, everything's like blah, 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 and we send them upstairs and we're like, all right, cool, everything's running, cool, yep, there we go. So it's so funny because like as long as everything's running, like we're like, well, you guys can figure that out, like, because we don't have time to sit there and like organize all these things. Like you're lucky if the bag is labeled, to be honest. Like you're really lucky if the bag is labeled. So yeah, that meme is like so funny because it's so true. What else? Let's talk about goals. So the ER, our goals is basically like the patient's coming in, we're triaging them, they have an acuity level, we're getting them back, and we're kind of treating the problem and we're trying to get them out. Like we're getting them out or we're taking them upstairs so they aren't, you know, stable enough or they aren't well enough to go home. But yeah, we're treating the main problem and that's pretty much it. So triage is very important, acuity level, you know, is important, but that's kind of how we run the ER. The ERs ran based on acuity level and how they're triaged and like things like that. But yeah, treating the major problem, treating the emergency, and then setting them up to like do everything else. In the ICU world though, it's like totally different. You're looking at the entire patient, you're looking at every body system, you're looking at how much they peed, how much they took in. Yeah, like as an ICU nurse, I would always be like, oh, you know, how much did they pee? Did they pee? How much output did they had? And you know, ICU nurses, like we would get mad, like why don't you know if they peed or not? Like why don't you know how much they urinated in the urinal or whatever? And I never really understood. Like I'm like, I don't understand why they're not, why they don't know if they peed or didn't pee and how much. But as an ER nurse, I like half the time I'm like, yeah, they might have peed. I think they did pee. I don't know how much. Like, oh, the diaper, I threw it away. Like I didn't weigh that. Like ICU nurses are worried about like every little thing. They're worried about kind of the overall picture, long-term goals, making sure that the patient is stable enough to go home. Like they're critical. They, you know, they're very, very sick. They're unstable. And they're trying to take a long-term process of them getting them better so they can get transferred to a different floor and then eventually go home, hopefully, right? So that is kind of the goals of the ICU. They're more, you know, they have better rapport with the patients and the families. They're building relationships. They're more involved with the patients and families. Like, you know, we're very friendly in the ER. Like we, you know, we speak and, you know, we talk to parents and, you know, we try to get the story of what's happening, but like we only see them for an hour or two, maybe 3 or 4 hours, maybe a little bit longer in the winter when we have holds down there. But for the most part, like we're getting them out. We just kind of see them and treat them and all this stuff, and like you don't really have that like long-term relationship or anything like that the ICU nurses have. So definitely different. I personally, you know, I liked having, you know, building relationships and things like that, taking care of the same patient day in, day out, like coming back, having like 4 shifts in a row and like knowing I was gonna have the same patient all 4 shifts. Like, you know, like I like that. What do I like more? I don't know, like I'm into the ER right now. So I think the ER, we talked about this a little bit, I think, but like Workstyle, to be more like in depth about it, ER, they basically thrive in the chaos. Like chaotic, we are loving it. Like we're like, you know, it's crazy and it's busy and sometimes we're like, we don't sit and all these things, but like at the end of the day, like we're an ER nurse because we like that. And it can be crazy, especially the winter. Like winter is like, oh my God. I kind of dread the winter, to be honest, in the ER. Like I absolutely dread it. Like have a waiting room of like 50 people and then you already have every room, like all 45 beds filled. And like as soon as you get rid of a kid, you're like getting another kid. Like it can be a lot. And you know, parents at that time get very testy and loved ones because like they're waiting in the waiting room and we feel like we're organized and like we're, you know, acuity and getting people back based on acuity and all these things, but like to the parent, like their child's sick and they need to get back. So I feel like everyone is kind of more on edge a little bit, just because they're waiting and the wait time can be 2-3 hours, 4 hours and whatever. So yeah, definitely can be crazy, but that's, we thrive in that. Like that's how ER nurses just, we thrive. ICU nurses, on the other hand, kind of like detest chaos. Like they want things to be just like structured, organized, kind of go, like not that the kid isn't sick, the kid is sick, but everything's just like kind of going, you know, like it's not like literally like this all day, right? So sometimes you get that patient that it is, but for the most part, they're sick and they're just kind of like riding this wave. And they don't want the chaos. Like I didn't want the craziness. Like I like taking care of the sick kids and like I wanted to be like busy and like, you know, continue to do stuff and things like that. But like I didn't want things to be bouncing off. Like no. So it's kind of weird. It's just crazy how I went from ICU to ER because I feel like I'm kind of like in the middle, you know, like my personality and everything's like right in the middle. So I can kind of like dabble in both, you know, so I don't know. ER, you know, works, they like thrive off teamwork. Like everything's a team. Like if I have 4 kids and everyone needs a line, like one of the other nurses in my zone is, you know, they can throw in that line and get laps for me. Like that's totally fine. Like you go ahead and do that, boo. Like, you know, so that's fine. And we kind of bounce off each other. Like we're doing everything together. Like everyone's patient. You know, like it's just, I know about like everyone in my zone, like all the patients, like, and what they need. If a pump is beeping, I can go in and shut it off. Like, that's kind of how we work. ICU nurse, like, I dare you to touch my pump. That's kind of how it is. Like, don't touch my pump, don't touch my lines, don't touch this, don't touch that. Like, everyone, they're kind of, not that they don't work together, because, you know, it's all about teamwork in nursing, but they're kind of like, they are possessive of their stuff. And that's kind of how I was. Like, I didn't want anyone touching my stuff. Like, I spent all this time making it how I wanted it, so don't touch it, you know? So that's kind of how it is. But what else? We can talk about a typical day in the ER and ICU, because they're a little bit different. So both ER and ICU are both 12-hour shifts for the most part. I mean, you can do blocks of 4 or 8 or whatever, depending on your unit, but for the most part, they're 12-hour shifts. So that's the same. The difference is you're gonna come in as an ICU nurse and you're gonna have 1 patient, or you're gonna have 2 patients. Like, there's gonna be no more than that. That's it. So it's 1-to-1 or a 2-to-1 ratio. As an ER nurse, you're gonna come in, you might come in and have no patients because there's no one in the department, or there's no one in your zone. So you come in and have no patients. You might not get your first patient until 10 o'clock or 11 o'clock, depending on the day. Like, you might get your first patient when you first come in. So it kind of just depends. But when it's filled, your ratio could be like four patients at a time, maybe 3 patients, maybe 5 patients. It kind of just depends on how the zone is going and how the other, you know, nurse in your zone is managing patients and things like that. So it can vary, but for the most part, you're gonna have 3, 4, 5 patients at a time. So definitely different in that aspect. Patients in ICU are gonna be sick. The 1 patient is gonna be very sick, because that's why you're a 1-to-1. If you have 2-to-1, they're still sick because they're in the ICU, but they might be a little bit more stable for you to be able to go 2-to-1. In the ICU, like, I'm not gonna leave the bedside. Like, if I have 1 patient and they're intubated and have all these things and they can deteriorate at any second, like, I'm not leaving the bedside. If I need something, I'm getting another nurse to come watch my patient while I go to the bathroom, or while I go to the supply room to get IV fluids and a line, or a med setup, or whatever. Like, that's what I'm doing. So I make sure that someone's always watching that patient at all times because they're sick, right? In an ER, you're having 3, 4, 5 patients, and one of the patients might have been there because they broke their arm. Like, that's, you know, you can break your arm or whatever. Someone might be there because they sprained their ankle. 1 patient might be there for something more serious and more unstable. You might have a trach kid in the mix of that. So everyone's gonna be a different acuity level and like what they're coming in for. So it's definitely, you know, not everyone's gonna be like super sick. Like, you're not gonna have 5 ICU patients, and you might, I don't know, but like at that point, you would hope the other nurses would come help you out and things. Like, I am gonna go to the bathroom. Like, I might say like, hey, I'm going to the bathroom, but like, I'm not like worried about someone watching all my kids, like specifically, like they have to stand by the door and watch my kids. Like, that's not what I'm worried about. I, you know, can roam and go to the supply room, get a med and things like that, and like be okay. Like, everyone kind of works as a team and things, so it's a little bit different. Like, I'm not so concerned about leaving the patient's bedside because, you know, it's the ER. Like, I have multiple patients, so I'm not always gonna be watching 1 patient. So it's a little bit different in that aspect in your day. When you're planning out your day, like, I am not writing anything down as an ER nurse. Like, I'm not. And as an ICU nurse, like, I'm writing everything down. Like, it's just so much different. Like, I remember as an ICU nurse, I literally would have my Cardex and I would like write down all the history. I would write down the lines, and I would write down like every system and like their assessment in every system of like report of what I was getting. I would write down social history of like things with like parents or guardianship and like all these things. And then on the back would be my schedule, and I would write down in every hour like what I had to do, when meds were due, what meds they were on, when labs were due, and all these things, like when to assess output and all these things. Like, I would assess, I mean, I would write it down in every hour. I would highlight stuff. Like, if I had something important that I did not want to miss, like, I would highlight it. I would use different color pens. Like, if I was like had downtime, I would like, if my card was messy, I would get a fresh card and I would rewrite everything so it's more neat. Like that's ICU, you know? As an ER nurse, I'm not writing anything down. Like I'm not. Everything's up here in my brain. I'm not writing down my schedule because no one really has a schedule. Like I'm looking at what the orders still need to be done and I'm doing those orders and I'm documenting it and that's it. Like I'm not writing down like, oh, I need to do an IV check in an hour. Like, no, I'm setting my pump for an hour. So when it beeps, I know that, oh, okay, time to check. But like, I'm not writing that down. Like there's no paper. Like I might, if I get an ambulance, I might take paper in if it's like, you know, like a longer story and I don't want to forget like to write things down that way because they're coming from like an outside hospital or they're coming from home or things like that. But for the most part, like they're giving me a report and I'm in my head and I'm like typing it in a triage note and like documenting it and that's it. Like there's no like, let's write down all these things. Half the time I don't even have a pen. Like I lose my pen like I don't know if it's just a nursing thing. Like I lose my pen like every shift. So yeah, that's kind of like planning your day. ICU nurses, if you like planning and doing all those things, that's definitely for you. If you're not and kind of just like go with the flow and just get things done and kind of, you know, when orders pop up, you do the orders, you put in the IV, you do the labs, you acknowledge it, and then you move on, like then ER is definitely for you. Assessment wise. So ICU nurse, when I would come in for my day, I would go in and I would do a head to toe assessment. Like I'm looking at their pupils, I'm looking at neurostatus, I'm listening to their heart and lungs, and I'm feeling their belly, listening to their stomach, looking at all their lines and all that kind of stuff, looking at their skin. I'm turning them over to look at their back and their butt, like changing their diaper. Like I'm doing all these things when I first come onto my shift as a full assessment. So I have a base of what, you know, everything looks like what everything looks like and if anything changed from the previous shift. Like that's what I'm doing. As an ER nurse, we're not doing like full head to toe assessments. Like if they're coming in and they're alert, they're awake, their airway's patent, like I am just gonna assess what the problem is. Like if they have a broken pinky, like I'm gonna assess the broken pinky or the neurovascular in the hand and things like that. Like I'm not gonna assess pupils, right? If they're talking to me, they're alert, they have no neurological deficit. Like I'm not gonna sit there and like say, open your eyes and look in your pupils. Like I'm not, you know? So that's kind of how it is. You kind of do focused assessments and things that they come in for and like do assessments based on that. They come in for like multiple things, like maybe like a lung or shortness of breath or something, and they also come in with like a broken hand. Then I'll assess both and just put in 2 focused assessments. Rounds happen in the ICU world, not in the ER world. Like you'll be lucky if you know a plan for the patient in the ER. Like sometimes like parents, I have to be like, oh, I need to go ask the resident what the plan is because they don't really update us as much as like in the ICU world, they're rounding. So you know everything that's supposed to happen, what's gonna happen, what the plan for the day is, all these things, what's going on with the patient. Like everyone's in the loop. In the ER world, like, you know, there's a lot of doctors that are good about it and they'll say like, hey, like this patient, we're waiting for this, this, and this, or whatever. But sometimes like you're like, I don't know why this patient is still in the ER. Like they need to be going home or they need to go upstairs. Like I don't know what we're waiting for because you just don't know. So that's definitely a different. So like overall, let's just say ER definitely more like reactive. Like we're gonna react to everything. We're gonna assess, react, treat, get them out. That's it. ICU is kind of like proactive. Like we're gonna anticipate everything that's happening. We're gonna have our push-pull set up. We're gonna have all of our emergency meds already like pulled up and all these things. We're gonna have labels already written out. We're gonna have everything basically preparing us for if something happens. Next thing, knowing the patient versus not knowing the patient. So ER, like you're not gonna know the patient. You're not gonna know unless what's already in the chart, if they've been there before or what the family tells you or what the patient tells you, like that's what you're gonna know, right? So sometimes, I swear this happens in the ER. They come in, they go to triage. They say like, this happened, I'm feeling like I have belly pain, whatever. So then they go from triage, they get, you know, their rapid assessment, and they go back to a room. So the nurse in the back comes and they get their assessment and their story, and they add something else to it. Like they say everything they said and they add something else because they forgot to tell the triage nurse. And then so you write all that down, and then the doctor comes in and then they're like, oh yeah, I didn't tell the nurses this, but this happened, or I'm feeling like this. So you get like 3 different versions of the story, and that always happens in the ER. And I'm like, I swear they did not tell me that. Like, so that always happens. So you don't really know the patient. Like, you can't like say this and that. So you're kind of just treating based on what the patient is presenting like, or what the patient says. But if you learn something new in like 2 hours, then that could change the whole course of the plan for this patient, right? And like, you don't know anything. Like, I swear, you like go in to this patient's room and you're, you know, you're doing like all these assessments, you're coming in, like this is before COVID, mind you. So you're going in, you're doing all these things, you're like holding the patient down to get a line, you're doing all these things, and then 3 hours later, you get like a result back that this patient has rhinovirus, or they have meningitis, or they have C. diff, or whatever the case may be, and you're like, I just touched all over this patient and I didn't have any protection on, and yeah, you know. So ER nurses just don't know. But ICU nurses, we had the privilege when I used to work up there, you know, getting report and knowing that this patient has rhinovirus, or they have RSV, or they have this and that, so you can properly protect yourselves. Like, it's funny, like this, the meme, like this is true. Like before COVID, like you would go in and you're lucky if like the ER nurses had a mask on. Like, we're just going in and we're assessing this patient and like we're getting out. Like ICU nurses are coming in with the whole thing, because that's just how it is. Like ER nurses, ICU, totally different worlds. We just don't know the patient. We're still getting to know them. We're still learning about them. We're still assessing them and getting the story and things like that. And the story, I swear, is forever changing, because they always have to say, I forgot to say this. But ICU nurses have the privilege to know everything that happened. Like, they had a whole ER visit. They know, they can read the doctor's notes and everything that happened, and then they have a better understanding when they get to the ICU. So it's definitely a little bit different. So if you like knowing and being prepared, then ICU. If you're okay with just not knowing and going with the flow, then ER, I would say. So yeah, that is ICU versus ER, and kind of the differences, my personal experiences with the both of them. I hope you liked the video. If you have any questions or comments, please leave them below. Please subscribe if you like this video and want some more. Please give this a thumbs up, and I will see you guys in my next video.